Hello, good morning. So I'm also up. It's a privilege to introduce my friend here, Dr. Damarsakti Suirakorn, who is presently the president of the Thai Coast Dermatology. Okay. So we know that keloid is a benign scar, but it gives like an emotional, distress to our patients. So this session is very timely for us, and we are lucky to have these two experts with us. And I would like to introduce the first speaker, Dr. Botra Atul, a dermatologist from India. Okay. He's he's a hair transplant surgeon also, aside from from the specialties that he has. Okay. Can you, so he will talk on optimizing surgical outcomes and ear keloids insights from a 50 case series.
Full screen. Go full screen. A very good morning to everyone present here. Thank you so much to wake up in the gloomy weather today and come for the presentation. Hi, I'm Dr. Atul Bothra. I'm a dermatologist and hair transplant surgeon from a small city called Guwahati in India. And so today I'll be giving a talk on optimizing the surgical outcomes in ear keloids, insights from 50 case series. So as we know, keloid is a body's abnormal wound healing process which causes significant deformity and morbidity to the patient. It has a very complex management because there's nothing first line, second line, third line when it comes to keloids. All the cases need to be individualized, and there are multiple triggers. So if for some person a small piercing can lead to a keloid, for others even a acne or a varicella can cause the starting of keloid. So the problem with the management is that the high recurrence rates, especially if the scar becomes larger than the previous keloid. So it becomes quite difficult to take care of the keloid. So especially in other parts of the body, we don't go for surgical managements, but in ear keloids, surgical managements are preferred. Surgical managements, though, single or alone without any other uh, combination, can cause a significant recurrence, and monotherapy with surgical excision alone is 55 to 70%. With monotherapy of intralesional corticosteroids is approximately 50 to 80% in different studies. So the need is for a combination treatment. The preferred treatment is first a surgical modality, followed up by management with pressure dressings, intralesional corticosteroids, cryotherapy, etc. So what are the additional management challenges which we face when it comes to keloids? There are many effective treatments carry risk of cosmetic problems, especially in individuals with darker skin types. There's lack of standardized protocol, so there is currently no universally accepted gold standard protocol. The evidence is quite low quality, like I could say 50 to 70%. So it's like a huge discrepancy in the studies when it comes to the randomized controlled trials, that what will be the result of a procedure. There's a variable treatment outcome depending upon the surgeon, depending upon the uh, patient characteristics, and leads a lot to the patient burden and quality of life. Now, the topic in action today, earlobe keloids, it has another unique problems. One, it is a very visible area, the ear, especially for females, and it causes a lot of psychosocial impact to the person. The primary goal is not just removal, but we have to restore the natural anatomy of the ears. The ears have to be symmetrical, otherwise it leads to a lot of cosmetic issues in the person. And the second unique problem is the lack of limited amount of skin and subcutaneous tissue in the ears. So we cannot take a risk of a larger skin surface margin. We have to be very conservative when we are going for the surgical approach in earlobe keloids. And the stimulus, the act of piercing again is something which is very dangerous. It can restart the keloid if we go for piercing again. So I would like to bring to attention this patient. This was a young boy, 17-year-old, underwent a piercing, and you can see the size of keloid which he has in the ear. and he used to carry this along with him. So this was the one of the biggest cases of keloid which I had done in the years. So what are the primary combination therapy or the gold standard, if we may call it as, is surgical excision, intralesional corticosteroids, pressure therapy. In surgical excision, the keloid is removed, the mass of the keloid in toto is removed with minimum tension on the wound closure. Alone, yes, recurrence rates are there, but combined, the recurrence rates significantly drop to less than 50% with proper post-operative injections as well as pressure therapy. Intralesional corticosteroids are the main adjuvant. They are typically triamcinolone acetonide in 10 to 40 milligrams per milliliter. They inhibit the collagen synthesis and fibroblast proliferation, given immediately post-surgery and repeated every 3 to 4 weeks for several months. Some doctors advocate not giving it during surgery to increase the risk of side effects like infection, but yes, others recommend at the time of surgery to prevent the recurrence. Pressure therapy, it causes a mechanical inhibition. Specialized pressure earrings or clips apply continuous pressure to decrease the blood flow and oxygen tension, inhibiting the collagen production. It must be worn 12 to 24 hours a day for 6 to 12 months for optimal results. So nowadays, even in common websites like Amazon, we get these pressure magnets which work as a good adjuvant post-procedure, post-surgical treatments to prevent the recurrence. There's some other specialized adjuvant therapies, like it can be a post-excision radiation treatment, cryotherapy or freezing, or intralesional 5-FU or 5-fluorouracil. The radiation therapy gives a highest rate of success in preventing the recurrence, and reports suggest less than 20%. Even some studies have given a 0% recurrence rate. Cryotherapy, it causes tissue destruction, used either as a standalone treatment for small keloids or in combination with intralesional corticosteroids. Intralesional cryotherapy is another new modality which can be used, which helps to prevent minimum surface damage. Herein, a cannula is inserted into the bulk of the keloid and the liquid nitrogen is passed through the cannula, so it just affects the keloid tissue and not the skin per se. Intralesional 5-FU, it's another alternative to intralesional corticosteroids or combined with it to inhibit fibroblast proliferation, used primarily for recurrent or corticosteroid resistant cases. So how do we classify the ear keloids? The ear keloids can be classified, and there's an article which is mentioned here, into 4 main types. The pedunculated type, where the surface contact with the normal auricular surface is less than 2/3 of maximum diameter and has a characteristic dark red to brownish discoloration. The sessile type, it has the longest diameter of the mass contact surface exceeding 2/3 of the maximum diameter, has a slight pinkish configuration. When we're classified into subgroups according to the presence of conglomeration, it can be a single nodular sessile keloid, it can be multinodular sessile keloids. Then we can have buried type of keloids, which has minimum to mild contour changes without discoloration. They are mainly palpated as a mass about 2 to 3 or up to 5 mm in the surface of the ear. And then they can have mixed type of keloids which has multiple keloids together. So these are the examples of the common keloids. We have the pedunculated keloid in the first, and then we have the single keloids, and then the multinodular and the buried keloids. So how do we go about the surgery? The first thing is the anesthesia. In case of small keloids, we can just go for a lignocaine injection underneath the keloidal surface. But if it's a bigger keloid, we need to go for something called a ring block, wherein a 1.5-inch needle inserted subcutaneously below the earlobe in line with the external auditory meters. We inject 1 ml of the anesthetic agent, which is lignocaine, plain without any needle into the spot of the needle entry, and then direct the needle behind the ear towards and over the mastoid process 2 to 4 mm deep and advance it parallel to the skin. And entire needle length should be inserted so we can make it like a ring, and it's also called the diamond nerve block. So basically we try to enter from the joining commissures and we give it towards the mastoid, and we completely fill the area up with anesthesia. Then for a pedunculated keloid, this is the simplest and it's the first keloidal surgery one beginner should try, wherein elliptical incision is made over the involved surface, including the base of the peduncle, and the cut was made down to an area where the majority of the soft tissue appeared to be normal fat, and then the wounds are sutured with a little minimum tension onto the skin. We can use a 5-0 or a 6-0 proline or an ethanol to close the wounds. Then the sessile keloids. Sessile keloids, now it's a little bigger surgery. So we have the two methods of doing a sessile keloid. We can go for something as a fillet flap method, or we can go for a wedge resection. In the fillet flap method, a keloidal flap is created, which is used to treat large or recurrent ear keloids. The surgeon dissects and saves the healthy skin overlying that keloid, removes the core keloidal tissue, and uses the preserved skin flaps to close the wound. So we have to separate the skin from the keloid, raise it like a flap, and again close it. Skin preservation is the goal. Carefully lifts the surface of the skin of the keloidal mass. Core removal is done. The dense fibrous keloidal core is completely excised, and the wound is closed back, folded back over the defect, and stitched, maintaining the natural shape and structure of the ear lobe. The advantage is it preserves an ear's natural shape, leaves a small and flatter scar, and allows for much easier post-operative treatment if the keloid returns. So this is a patient wherein I had done a fillet flap method. So if you can see, she has a multinodular keloid, both in the anterior and the posterior surface. And also there was a little bit of a buried keloid too, along with it. So we had done the fillet flap method for this young girl. And this was the scar, and this was the result post doing the procedure. As you can see, complete flattening. And she has been followed up for approximately 9 months now with no recurrence. Now coming to the second thing, which is the wedge resection. In a wedge resection of an ear keloid is a surgical technique where the surgeon cuts a V-shaped section of the ear, including both the keloid and a margin of the healthy tissue. It is frequently used for keloids located on the earlobe or the helical rim. Why wedge resection is done? It is a radical excision, allows for complete removal of the keloid root, which dramatically lowers the risk of it growing back, and volume control. If prevents the ear from looking stretched, elongated. So many of the times when people have keloids, the skin also grows along with the keloidal tissue. So there's a lot of extra volume, and to maintain the symmetry and the architecture of the ear, a wedge resection is preferred in such cases. So example, this is a patient, and there's an example of the pictures diagram as well, how a wedge resection is done. And this is a patient where we have done the wedge resection. So if you can see, we have removed V-shaped skin with the keloidal tissue and then sutured it back, maintaining the architecture to as normalcy as possible. Then we have something of the buried keloids. Buried keloids is something wherein it's a track-like keloid along the piercing site. So keloid core underneath the skin flaps excises meticulously. Typically the keloid grows through the pierced track covering the overlying skin. Therefore penetrating both surfaces was necessary to prevent an incomplete excision. It's also called as a core extirpation or a penetration technique. If it's a small keloid, we can go for something like a punch, the disposable punch which is used for biopsies, and we can take from both anterior and posterior aspect, and we can remove the keloidal mass with the penetrating tract in toto. So now coming back to the same boy where we had done, which was the first one, this was the result of him after 1.5 year follow-up. So if you can see, we had done a wedge resection, we had followed it up with intralesional corticosteroids and pressure treatment, and it prevents the recurrence and managed the architecture also more so well. So what were the results from our case series? So in amongst the 50 patients, we had done the ear keloidal surgeries. Sessile, uni and multinodular keloids are the most commonest keloids. Satisfactory to excellent cosmetic outcomes were achieved in 84% of the cases, and good wound healing without significant complications were seen in 90% of the patients. Recurrence, mild recurrence were seen in 12% of the cases during the follow-up, and post-operative intralesional triamcinolone and pressure dressing was well tolerated with minor transient adverse effects and noted in 8% of the patients. What were the complications which are known to occur? One, recurrence rate as we have discussed. Second, infection, post-operative wound infection or abscess. It's high if the cartilage is involved. Hematoma or seroma formation. So if it's a bigger keloid, we can put a drain for the first 48 hours so that the seroma is not there. Wound dehiscence, due to tension on the wound edges or poor surgical technique, predisposes to hypertrophic scarring and recurrence. Cartilage necrosis or chondritis, especially when the helix or antihelix are involved. Cosmetic deformity, hyperpigmentation, hypertrophic scarring, pain and sensory changes are the other complications which are known to occur. Complications related to adjuvant therapy can also be seen with steroids, a little bit of atrophy of the skin, telangiectasias, hypopigmentation. With pressure earrings, ulceration, discomfort if it's too tight, so we have to make the patient understand how to use it correctly. Radiotherapy, rare risks such as chondritis, pigmentation changes, and theoretical carcinogenesis. What are the complications which we saw? A little bit asymmetry. If you can see in this lovely lady, a little notching is present after the surgical removal. So this is sometimes it can happen, though it was accepted by the patient very well, but still we can try to maintain it. Second, recurrence. This is a large keloid, so after about 9 months of surgery, the keloid started to recur back in the edges. So we had to resort to long-term usage of intranasal corticosteroids and pressure therapy, and it's still small, but yeah, it's still not completely gone. So what advice I would give to like beginners or some people who are not doing ear keloid surgeries? So we can make our life easier by following a few things. One is intraoperative hydrodissection. What is done is normal saline is injected into the keloidal tissue by entry to the normal skin and avoiding the damage to the flap. So what happens if we put saline below the skin surface and above the keloidal mass, there's a space to operate and we do not damage the skin. We can just, especially when we are doing a flap technique, so we can save the skin, so we can separate the skin from the underlying keloidal tissue by injecting a good amount of saline till the skin becomes blanched and separating it from the underneath layers. Second is we can use a 24 gauge needle to reduce tissue handling. So when we do a surgery in the ear, it's very difficult to stabilize the ear. So there are two ways where we can stabilize. If it's a smaller one, we can use a Chalazion clamp and we can just apply it in the ears and it will help in stabilize the ear. Second, we can just take a 24 gauge needle and we can introduce the needle into the bulk of the keloidal tissue. And then we get, at least we know till where we are removing the extra skin and the keloidal tissue so that we don't damage the normal tissue along with it. So pre-operative, if we can just put a 24 gauge needle, it works like an anchor for our surgeries. Post-operative pressure dressings and magnetic clips like I already discussed, and avoid piercings in the future. So this is something called a protractor-like dressing or a pressure dressing which we use post-procedure. So we put this kind of dressing for the first 10 to 15 days, and later on also we can ask the patient to use these dressings. These dressings put the pressure under the normal keloid, so it works like a pressure. So to conclude, surgical excision, if you've seen in the images, continues to be a cornerstone of management of established lesions. Yet alone, it's often associated with unsatisfactory outcome and high recurrence rates. In this series, meticulous surgical excision with tension-free closure combined with structural post-operative adjuvant therapy formed a basis of a treatment. Our findings provide practical guidance for clinicians and reinforce the role of combined modality as a standard of care in ear keloids. Thank you.
Thank you. You done very nice job. Beautiful. And have any question from the floor or any discussion? Please feel free, because it's a small group. We can share together.
Any questions from the floor? Doctor, I have a question. After the surgery, do you readily inject corticosteroid, like the 40 milligrams, right after?
So, ma'am, this is actually a little controversial. So, there are articles which are mentioning that yes, we have to inject. I do. Sometimes I do. Unless there's a patient where I see a lot of bleeding, a lot of chances of infections are more. If this patient is a little borderline diabetic or a diabetic, then I choose to ignore. Otherwise, 40 milligram of triamcinolone only under the base of the keloid helps preventing the recurrence.
Do you always combine 40 milligrams corticosteroid and 5-FU?
No, ma'am. We do not combine both the things. I think we prefer to go for intradermal corticosteroids alone. But yes, in some patients, especially the patients where we are going as a single modality of corticosteroids, where we are not being able to go for a surgical option, then we combine 5-fluorouracil with hyaluronidase with intralesional corticosteroids. We are giving, it's a cocktail of the 3 molecules. They are used not just in the ears, also in the chest keloids and where bulky keloids. The 5-FU helps in reducing the bulk very fast, though it's a very painful injection. So otherwise, it helps a lot.
So how do you cut? For example, this is the keloid. So what I understand is you debulk and then you maintain the normal skin.
Yes, ma'am. So, ma'am, like we discussed, there are 2 common ways. One, we can raise a flap So we can just open the keloid from both the sides, debulk the skin
Yes.
completely, and then close the flap.
Okay.
Or second option is you can go for a wedge resection where the keloid and the tissue are cut and the ears are joined. So that changes the ear morphology a bit.
But then you also debulk it and then do
Yes.
that. Yes.
So in a wedge resection, ma'am, we are just removing the entire, something like a, when we see a ear piercing induced cut, something like that, we just open the keloid from both the sides and complete skin is removed and then joined back. So the goal of keloidal surgery always remains to remove the keloidal tissue in toto. We should not let any keloid, we should try at least to avoid any keloidal tissue be there, otherwise the chances of recurrence are good. We also have a few patients wherein the keloid was too large, we could not suture it so well.
Oh, yeah.
So even they with secondary intention healing also, it heals quite well. It takes more time, but even then it heals. But if a little bit of keloidal tissue is remaining, it tends to grow back again. So we have to make sure it's completely free. We can see the healthy layer of fat or the a little bit of cartilage, but we should not let any keloidal tissue be there.
Okay.
And do you use the pulse dye laser?
Ma'am, pulse dye laser in the years I haven't used, but for chest keloids, the vascular keloids, their pulse dye lasers we have tried, and even nowadays fractional CO2 laser, if it's a large surface area keloid, where we have tried the fractional CO2 laser as a drug delivery mechanism, and then where it's practically impossible to give the steroids because the dosage would be very high, almost covering the entire chest, entire back. Then we use a fractional CO2 laser mediated drug delivery as a protocol too. Yeah, that also works. Yeah.
So do you also operate on the chest?
No, ma'am. Chest keloids we do not operate because of the high tension in this chest area. The recurrence which will be much larger than the original keloid too.
Or even if you just debulk it?
Ma'am, debulking can be done if it's a big keloid, just to ease the patient pain
Okay.
and all. But the recurrence rates are quite high in the chest keloid, so I haven't done, ma'am.
I'm sorry. Yep.
So much. Fernando Valenzuela from Chile. Do you have any experience on keloids in children? I worked in a burnt hospital, and I have some issues because of the growing hormones. It's more difficult to treat them, and the recurrence is higher.
So pediatric keloids is a very challenging condition. One, because first the patients are not compliant. Secondly, we cannot use steroids too much, or we cannot go for surgical options easily. Thirdly, because of the growth hormone, or because of the rapid growth, they tend to recur very commonly. So we do not operate in children because of the same reasons. I have done 1 year keloid for a 7-year-old girl, but it also recurred very fast. So, but yes, nowadays, sir, there are some special pressure garments which are available, and children, especially post burn cases, when they have the chest or trunk lesions, even in the healing phase, if we can start putting the pressure garment, it really helps in preventing the keloid. Secondly, the silicone gel sheets in proper way. Third, nowadays, that even a topical molecule called as pirfenidone is available. We can try to use that, but it's a very challenging condition.
Thank you so much.
Thank you. Have any question from the floor? Please.
Thank you for your speech. So could you explain the specific procedure for cryotherapy?
Can you please repeat the question, ma'am? Procedure for cryotherapy?
Yes.
Cryotherapy, there are 2 types of cryotherapy which are done in the keloidal surgeries. One, we can just spray the liquid nitrogen directly into the keloid over the texture of this, over the surface of the keloid, and then we follow it up with the intralesional corticosteroid to maintain the effect. Therein 3 passes of 30 seconds to 45 seconds of freeze-thaw cycles are used. But the problem therein is only the textural changes, hypopigmentation and ulceration which might occur post the procedure. Secondly, the new thing which is being tried is something as intralesional cryotherapy, wherein a cannula or a needle, wide bore needle, is introduced into the bulk of the keloid, and the cryo gun is attached to the needle hub, and the cryogen is passed through. In this way, the liquid nitrogen goes into the bulk of the keloid without damaging the surface of the skin. So that is one thing which can be tried, but single modality, it's not that effective. Combined with corticosteroids, still gives some decent results.
Thank you.
One more. Have you heard of the combination of triamcinolone, the 5-FU, and hyaluronidase?
Yes, ma'am. So, ma'am, there are two schools of thought here, two protocols which I used. One is the 9:1:1 ratio, wherein 9 parts of 5-FU are taken, and we dilute the hyaluronidase, as you know, it comes in a powder form. So we dilute the hyaluronidase with triamcinolone acetonide 40 mg, and we combine a ratio of 9 parts of 5-FU and then 1 part each of hyaluronidase and triamcinolone acetonide. And there's another school which say a ratio of 3:5:1:1. So the ratio of 5-FU varies in different case reports. I practically follow 5 parts 5-FU, 1 part hyaluronidase, and 1 part triamcinolone acetonide.
So you want the latter one?
Yeah. So that's lower volume, so it's more safer.
And you have a very good result?
Ma'am, in the chest keloids, yes. So in some patients where we have tried intradermal corticosteroids for multiple sessions, and they tend to recur back, especially in the pre-sternal keloids, there if we combine, it gives a much faster result. The only side effect is some patients can get a little bit of ulceration into the keloids. So that is one thing which can happen. 5-FU being an anti-metabolite, it can cause a little bit of ulceration. Otherwise, the results are a little more stronger. But we have to do the procedure with complete anesthesia because it's a very painful injection.
That's right, yeah.
Okay, thank you very much.
Thank you, ma'am.
Very nice job. For the next topic, I would like to introduce Dr. Kemkar Menna. She is a dermatologist from India. She will present a comparative study between intralesional steroid and topical pirfenidone gel vs intrasteroid monotherapy in management of keloid. Please welcome.
Thank you, Dr. Atul, for enlightening us on the surgical treatment options for keloids. Good morning. I'm Dr. Meenakshi Khemka from India, and I'm going to speak about the comparative study between intralesional steroid and topical pirfenidone gel versus intralesional steroid monotherapy in the management of keloids. Keloids, as Dr. Atul wonderfully introduced to us, occurs due to aberrant wound healing and causes significant distress to the patients, namely pain, pruritus, limitation in joint mobility, contractures, wherein the scar grows beyond the wound margins. It often poses as a difficult to treat cosmetic and dermatologic challenge for the physicians. Intralesional triamcinolone acetonide injections have been used as a gold standard technique, but they come with various side effects as well. Pirfenidone is classically an anti-inflammatory, anti-fibrotic molecule that is used for idiopathic pulmonary fibrosis, but a novel topical formulation, 8% formulation of the gel, has been recently coming around. So we have tried to combine the therapeutic effects of intralesional steroid injections at 20 mg per ml strength with pirfenidone 8% gel thrice daily to enhance the therapeutic outcomes for keloids. The objectives of our study were to compare the efficacy of intralesional triamcinolone with topical pirfenidone gel versus intralesional monotherapy in keloids, and also to compare the adverse effects between the two treatment methods. It is an open-label, randomized controlled trial with a study duration of 12 weeks conducted among the patients attending our dermatology OPD with a sample size of 36 in each group. The study is both ethics and CTRI registered in India. We included patients aged 18 to 70 years old who were previously untreated with informed consent. We excluded pregnant and lactating mothers, large keloids that are unsuitable for steroid injections, hypersensitivity to ILS, pirfenidone, or any of its components, any surface changes over the treatment site such as secondary infection or ulceration, and patients with high expectations. After written informed consent, data on medical personal history and demographics, we took clinical photographs of the keloids and assessed the keloids baseline with modified Vancouver SCAR score. Group A of patients was given only the intralesional steroid injections at 20 mg per ml strength 3 weekly, and group B of the patients was given intralesional steroid injections along with pirfenidone 8% gel. Both the groups were assessed up to 12 weeks of therapy. The various parameters of modified Vancouver SCAR score are vascularity, pigmentation, pliability, height, pain, and pruritus, and it is total scored from 0 to 18. 36 patients were recorded in each group with comparable baseline characteristics such as mean age and gender distribution. The mean plus standard deviation of modified Vancouver SCAR score in group A, that is the steroid monotherapy group, was 9.28 plus minus 2.94, and the combination group with pirfenidone was 9.78 plus minus 3.16. At week 12, we saw the mean plus standard deviation scores to be 5.69 plus minus 2.28 in the intralesional steroid group and 5.06 plus minus 2.35 in the intralesional steroid plus pirfenidone group. We run two primary statistical analysis on our data, repeated measures ANOVA and ANCOVA. Repeated measures ANOVA, the main effect of time showed a p-value of less than 0.001, signifying that both the treatment options were effective to reduce the modified Vancouver SCAR scores. However, the time into group interaction showed a very interesting finding that the trajectory of improvement differed significantly, favoring the ILS plus pirfenidone group. To adjust for baseline SCAR severity, we run an ANCOVA test. The ANCOVA test also preferred the combination therapy group, and lastly, as a supportive measure, we run an independent samples t-test on the mean difference in scores from week 0 to 12, which also favored the combination therapy group. Here is a graph. The blue line indicates ILS plus pirfenidone and the red line is for the monotherapy group. We can see that the trajectories are diverging around 6 weeks, and the blue line, that is the combination therapy, is achieving better results. Amongst the individual parameters, vascularity and pliability achieved significant p-values. Treatment-related adverse effects were studied at week 12, the presence or the absence of them, and we studied two main adverse effects: steroid-induced atrophy and dyspigmentation. Interestingly, we saw that patients who received the topical pirfenidone gel had fewer adverse effects compared to the monotherapy group. Here are some of the clinical outcomes of the patients we treated. The t-test, repeated measures ANOVA, time into group interaction, and the ANCOVA, all three supported the same result on our data, that the combination therapy group patients improved over the ILS group, although both the patients received treatment and were improving. Together, these findings consistently supported the superiority of ILS plus pirfenidone gel over ILS alone. Among the individual parameters of modified Vancouver SCAR score, vascularity and pliability achieved significant p-values, And the Fisher's exact test showed that the p-value was 0.004 for steroid-induced atrophy and 0.017 for steroid-induced dyspigmentation, concluding that the combination therapy group patients improved better with fewer side effects. Intralesional steroid and intralesional steroid plus pirfenidone both significantly improved keloid severity. However, combination therapy achieved greater reduction in modified Vancouver scar scores than intralesional steroid alone. This benefit remained significant across the 3 analytical tests that we conducted. Topical pirfenidone appears to be an effective and safe adjunct in keloid management. Innovation in medicine is discovering novel treatment options for common diseases. Keloid is one such dermatological challenge that inspires us to think beyond the convention. Topical pirfenidone 8% gel is an emerging treatment modality for keloids. The limitations of our study was a short follow-up period. Also, pirfenidone might now be studied as a standalone molecule to see its true efficacy in the treatment of keloids. I would like to thank my mentors and MCAS Asia for providing this wonderful stage to me. These are my references. Thank you.
Thank you. And please explain about the medicine, the topical phenidine. What is this? Because in my country, they have no this gel.
Topical pirfenidone gel, as far as I am aware, is available and approved only in Mexico and India. So many of our reference studies were Mexican as well. It is an antifibrotic drug that was earlier introduced to treat idiopathic pulmonary fibrosis. It inhibits the TGF-beta-1 pathway and it suppresses the fibroblasts. A novel topical formulation, 8% gel formulation, is now available in our country and in Mexico as well, that suppresses keloid-derived fibroblasts by the same mechanism as it acts in idiopathic pulmonary fibrosis.
Okay, please.
Thank you so much. Very, very interesting. Do you have any experience on monotherapy or mesotherapy with this gel?
Not monotherapy or mesotherapy yet, because it is a new molecule. The protocol of the study was that we cannot deny the patient's treatment. So we have to give both the groups a treatment that is gold standard, that works, and this can be introduced as an adjunct to see if there is any difference in treatment outcomes.
Thank you. It was interesting because I'm thinking on my children with keloids. Sometimes they are very afraid of the intralesional corticosteroids, so maybe this is an alternative for them, less painful and...
There is one pediatric, I think Mexican study done on children in keloids that used this topical pirfenidone gel. That was one of our reference studies.
Thank you.
Please show the photo of the clinical. Please show again,
Yes.
because it's very fast.
Okay.
Please explain this photo again.
Yes. The first photo, we see a patient that received topical pirfenidone gel with intralesional steroid. Over here, we saw that the pliability of the scar, the pliability was significantly reduced, which obviously we will not be able to understand via the photograph, but that is what the data proved. The second photo also we have intralesional steroid with topical pirfenidone gel.
Do you have a pointer? Do you have a pointer?
This one is the first patient and the second patient. In both the treatments we saw with pirfenidone, the pliability of the scar significantly reduced along with the vascularity. The pliability we won't be able to make out from the photo, but we can see a significant reduction in the keloids. This photo, it shows the steroid-induced atrophy and hypopigmentation around the margins and hyperpigmentation on the keloid. This is the monotherapy group. This scar, post-surgical keloidal scar, this one also received monotherapy with triamcinolone, and this one was a combination therapy group. We can see the keloid has reduced in size.
Have you tried occluding the gel? Occlusion.
Occlusion. The patients were advised to occlude with a micropore, but that depends on the patient compliance. Occlusion would definitely, or pressure, would enhance the outcomes.
Is there a history of allergy?
Pirfenidone might be photosensitive, so it is preferably avoided, or a sunscreen is used if it is used on the photosensitive areas. But in our study, we did not find any such finding.
Thank you.
Any question from the floor? Okay.
So if there are no questions, then we can, conclude this session. A very good session on keloid. Thank you, doctors, for the wonderful presentation.
Okay, today they have only 2 sections. Okay, thank you so much for the early morning joy.